was a delight to see so many of you in and around the platform, taking advantage of all the tools on offer. We're diving straight into the topics now too, with our fourth panel discussion. All the content will be available on demand in 24 to 48 hours after the event, so don't worry if you've missed something earlier. Our next panel is going to be tackling the role that estates and facilities teams and the general NHS state has on infection prevention and control. Even with the greater strategies in place, it's only as we carry out the care within and the people behind those facilities. And we've learned over the years that there are many innovative approaches that we can take to maximise the role of our buildings and those who keep them operating can do to support the infection prevention. From innovative new build hospitals, such as rounded corners, easier to clean, through to the renovation of our older Victorian era estate. The hard FM teams have real opportunities. Elsewhere, our FM teams, from cleaning through to the hospital laundry, can make huge differences to the IPC successes our hospital or healthcare site experiences. So, you know, telling you about that, why don't I let our guests tell you more? Joining me on the virtual stage this afternoon are Chris James, board member of the British Cleaning Council, Gillian Lishman, acting matron for infection prevention and control for the Newcastle upon Tyne Hospitals NHS Foundation Trust, Murray Gate, sales and marketing at Westgate, and Dr. Christian Peters, consultant microbiologist at Queen Elizabeth University Hospital. As with all of our panels today, if you have questions you'd like to put to our panelists, then please use the live Q&A function and we'll look to direct as many as we can to our guests. So welcome to you all. Thank you very much for spending the time to be with us today. It's very much appreciated. Christine, if we may start off with you, you're a microbiologist at Queen Elizabeth University Hospital. Can you maybe set the scene for us and explain, you know, what happened in your world when the pandemic struck and how it was handled?
Yeah, so as a microbiologist, obviously we're involved in diagnosing infections and keeping a lookout for any unusual infections. And the challenge, it's already been talked about in quite a lot of the panels this morning, that every single team in the hospital was affected this time by what was thought to be an infection or an infection control issue. So from the microbiology point of view, it was diagnostics, it was dealing with secondary infections in the hospital, and the infection control team were having to prioritise the kind of policies that had to be changed. And there was a huge amount of effort, especially in the first few weeks, to just reorganize the whole hospital. So currently I'm not the infection control doctor for our unit, but we cover at nights and at the weekends. So there had to be a lot of communication because obviously people coming in at the weekends and out of hours. And there were a lot of changes in the guidance that everybody had to be kept up to date with. The other aspect of it for me was laboratory safety. So, you know, we have a lot of staff working in labs. So not just the threat from the viral samples coming on or the samples coming in from patients, but also it being a place of work, like any other place of work, people working next to each other. So a lot of risk assessments, a lot of problem solving, PPE issues, and then just trying to keep up to date with the literature like everybody else. There was so much, such a volume of information. I'm sure everybody finds the same. And how does that apply to what we need to do today? And so it was completely changed. Everything was on its head. But at the same time, I think there were fundamental principles that we could apply. So if you understand the basic routes of transmission, that really points you in the direction of what actions you need to take.
Involved in today's conference, it was quite a roller coaster ride for you. Gillian, acting matron for infection prevention and control at the Newcastle upon Tyne Hospitals NHS Foundation Trust. Paint a picture of it, the pandemic, and as if you would, Jill.
I think very similar to my learned colleague, and it's been alluded to throughout the day. But I think for us, we were very fortunate with being in the northeast. We had a little bit more time for preparation that some of the London hospitals did. We learned a lot. And I think what we did was actually come together very rapidly and actually adopt an approach of flexibility of thought. And that's what I mean is we actually thought, what have we got to deal with? What can we do? And how can we best manage our patient population? And so we quickly built on the mechanisms that we'd actually been using for some time to ensure that we met very regularly. And we met at least once a day to actually look at how we could have managed patient flow, what was coming through the door, how we could increase intensive care capacity, where were the safest places within the organisation to place these patients, and how we could actually protect our patients and also ensure that we protected our staff from ensuring we actually sourced the PPE that was needed for them. So it was a huge challenge, but it was actually a bringing together of every discipline within the organisation to work effectively together. And it was an approach that was adopted by the portering staff, the domestic staff, the estates staff, right the way through up to the executives.
You know, it makes us, at times like this, it makes us just extra proud of our NHS. I mean, the NHS is already often, and hearing today what went on behind the scenes, you know, on top of normal patient care has really been quite inspirational. Murray, you're at Westgate. Tell us how you had to adapt your offering to adapt, if you like, to the changing needs of hospitals during these unprecedented times.
Sure, yeah. Well, at Westgate, just to give a small amount of context, we provide temporary partitions and semi-permanent hygienic modular partitions for segregation within hospitals. So pre-pandemic, that we were normally working where there's been building works in the hospitals, and we was cleanly segregating them from the live environments. The pandemic hit, and obviously we've got a lot of demand for segregation with for obvious reasons. So we were engaging with a lot of hospitals for creating the likes of single bed isolation rooms and negative pressure rooms. And we're looking at turning sort of existing 6-bed ward spaces into 6 individual bay spaces. So we worked with a lot of hospitals throughout the country. And then very quickly into the pandemic, the idea of the Nightingale Hospitals came about. And we worked very closely with some of the delivery partners on that, providing the complete partition fit out for those Nightingale Hospitals, which obviously they needed to be very, very quickly mobilised, offsite manufactured, and very, very quickly installed on site. And everything was happening all at the same time. So for us, it was a bit of a whirlwind, but we were very, very glad and very proud to have been able to support this initiative. And most of them were mobilised within 5 days from the initial the idea coming about to the partitions being fully installed. So that sort of kicked off our journey within the pandemic, and since then we've been supporting the likes of the NHS Test and Trace programme, also with putting up pop-up test centres around the country, and the list goes on. But hopefully that gives a bit of a flavour as to how our core offering had to be adapted during the pandemic.
It does. I want to remember to come back to you about the Nightingale Hospitals, because actually we've not talked about them at all today. When we talk about future builds and, you know, what we need to sort of do for future hospitals, remind me, I need to come back to that. But I'd like to bring obviously Chris into our conversation. Chris, you're at the heart of the British Cleaning Council, and some say that routine cleaning is the foundation of infection prevention and control. What are your thoughts, and how extra vital has it been over the last 18 months?
Well, I think from my point of view, or from the cleaning industry's point of view, there has been a view of what the contribution that the cleaning industry makes to the infection prevention and control within the hospital. And I think that in a very real sense, the removal of soil is actually 80% of the cleaning that needs to be done. So the sense that you have a soiled environment, starting with the general cleaning, then you've got the notion that by removing 80% of the soil and microorganisms using routine cleaning practices, that you can keep things pretty much safe as they are. The problem that we faced was, whilst that was okay for most routine cleaning, the introduction of the COVID virus and the ongoing things such as C. diff throughout the hospital has meant that the introduction of disinfectants of one form or another, particularly disinfectant detergents, have had to be introduced to ensure that there is a higher degree of cleanliness than otherwise be there. But I think in a very real sense, the hospitals are going to have to, at some stage, look at the routine use of disinfectant detergents and say, is this good long term? And isn't it about time we consider reversing out of this situation and going back to a situation where perhaps the mainstay of cleaning in the hospital is neutral detergents, which are the routine things like fairy liquid type detergents, and that the use of the disinfectants are restricted for specific usage where and when needed, but not routinely. And I think so from the point of view of what the contribution of the cleaning industry so far has been, that we've managed to keep it under control. I think that we've managed to contain it so far as we go. But I think that the issue for me in one very real sense is reversing out of this and making sure that everything reverses out safely as possible, because I think there is a very real probability that surfaces are being damaged by the overuse of disinfection.
Chris, reverse out of it safely, if you like, and what sort of cleaning good practices do we keep now?
I think the reversing out of it is something which has been, I think, discussed by a lot of people. And I think that, first of all, a word of caution that we'll start to reverse out of it when at last we come to a view that the various variants of COVID have reached their mutation changing point, that we're not going to get more variants coming through which would require us to suddenly change the position. And I think the safe position is to steady as we go, because it's the easy position to take. And what we don't know is how long the virus is going to be with us for. And we've had the, first of all, the original Wuhan variant, followed by the Alpha variant, now the Delta variant, each of which is more infective. I think the problem faced by the hospitals at the present time is deciding at what point we've reached the last version of the virus, and frankly, I don't think we have. And therefore, reversing out of it is something which I think we can talk about conceptually and notionally. But I think at this stage, until we know that we've reached the end of them, I think we'd have to consider probably steady as we go with the current policy, but potentially are looking towards reversing out of it as we go forward, and as perhaps more and more information comes to us. For example, the notion that the contact surfaces need to be routinely cleaned, when we're now beginning to realize that much of the transmissibility of COVID isn't from contact. In much of it is through airborne droplets and through perhaps airborne, and therefore the use of the cleaning of much of the contact points, whilst it does provide us with a safe, secure action that we can take, it isn't necessarily doing everything that it needs to do to prevent the spread of the virus.
You were nodding there, and I was going to ask you anyway your thoughts on what Chris was saying, because I mean, doctors are very much involved, aren't they, in the building issues in hospitals and the cleanliness side.
Yeah, so as a microbiologist, clinical microbiologist, this is bread and butter. You know, we're trained to try and prevent infections because prevention is always better than cure. And so a lot of our training does actually involve buildings and ventilation. Some people find that a bit confusing. Why is a doctor caring about drains or air movement? But in fact, it does come back to the point I made at the beginning. What measures you put in place really depends on how you understand the organism or the pathogen, the bug, moving from person to person. And it's become increasingly clear over the last 18 months, even though some people at the very beginning did identify this as primarily a disease of shared air. So when it's in the air, and you inhale it, that is what sets up the infection. And we put a lot of investment into cleaning. And as a microbiologist, you know, I'm always going to be pro cleaning and hand washing. That's really, that should be our baseline level of hygiene in a hospital. But what extra things did we need to do, and what do we continue to need to do in the hospital environment? And that is, we need to think about this air and the options that you have to reduce the risk, the bioburden. We've already talked about air scrubbers and ventilation. These are really important. So diluting, getting fresh air into the space and diluting down the number of viruses in the air so that the chances, the probability of getting infected are so much lower. And the other really important aspect is PPE. So surgical face masks are not designed to prevent the aerosols being inhaled, because there's always gaps around them. So having a good filter and a good fit is what prevents inhalation of aerosol. So I think that, as we mentioned earlier, ventilation didn't really come to the fore as a measure that everybody was talking about. Even in public messaging, it wasn't until about February time that there was those videos showing the green air coming out of somebody's mouth and open the windows. So the virus hasn't changed how it transmits. The variants haven't changed in their physics, they've changed in their biology. So how many viruses you need to cause an infection is maybe lower, or the extent to which it'll cause severity is different. So the biology is changing, but the physics isn't changing. And the physics is what determines the importance of ventilation. So I'm personally been interested in ventilation for 20 years. And, you know, our baseline in our hospitals is poor. And I think that is, we are reaping what we've sown for the last decades of non-investment in hospital. You've already mentioned the old estate. A lot of people talked about that even in the very first keynote speech, but even new buildings. So unfortunately in Scotland, we've got 2 new build hospitals, and there's a public inquiry going on into them because they have not been built in a way that would reduce infection as per the standard. So we've got a lot of rethinking to do. And I think what the pandemic has done is given us that wake-up moment that these things which we knew were important since a long time, the first document is 2002, infection control and the built environment. It's there, it's been in the standards. So what we need to learn is how to learn. We had the lessons from a long time ago. So how are we going to make sure this time round we're actually going to do what we know we need to do going forward? And I think that's our challenge. You know, we are, thank goodness we have vaccine. It's given us a huge stepping stone to recovery, but it's not the only thing. We really need to focus in on air. We have done cleaning, we've done hand hygiene, and that's right and proper and needs to be still there. But where the gap has been, this massive gap, has actually been an ability to deal with the airborne risk.
It's such a shame, isn't it? You're talking about 2 new build hospitals. Without the ventilation required. I mean, you know, even I know that, and I'm not in the health industry, when I visit, you know, the old part of the estate, and there's just no ventilation at all. You would think that was a fairly basic lesson way pre-pandemic. Jill, I'm just wondering whether you think there needs to be greater cooperation between estates and clinical teams to carefully manage infection control, particularly as we hopefully, fingers crossed, exit out of the pandemic and return to less hospital settings.
Yeah, I definitely do. I have to say we have been very fortunate in the North East because we've always had a long-standing collaborative approach with our estates department. And furthermore, we're in the process of looking at some new build areas. And I and my microbiology colleagues have been involved from the very beginning. We're discussing ventilation. We're looking at passive house, which is another element, and where we're looking at conservation. So I think it's absolutely key that we marry up what we want to build, how we're going to build it, with the professionals and the authorised engineers who are experts. But one other area I think is very important to consider, because I'm hearing an awful lot of noise in the press, and actually and when you actually investigate, looking into some of the building companies of recommendations of cubicles, and we need to really make sure we marry up what our workforce planning for the future is with what our building is going to be. And what I mean by that, we can't have huge capacity of cubicles and not have the workforce to look after and work in those environments. And actually, on a more humanistic viewpoint, I've been collaborating with our intensive care matrons prior to coming to this presentation, and I think something that's very important is that we need to be able to cohort some of our patients and we have done that in Newcastle. So we cohorted our COVID positive intensive care patients, which I'm sure a lot of my colleagues listening to this will have also done, and that gave the opportunity for people in the nursing and medical profession to work collaboratively in a common environment. So I think collaboration is key, and I think it's very important that we build something that's actually sustainable and going to work for everybody. And I believe we're actually going to be doing this in Newcastle in the near future.
Pretty exciting. This seems an appropriate time to come back to, you mentioned the Nightingale Hospitals. What did you think to the Nightingale Hospitals? Do they support the buildings of hospitals for the future? Did they tick all those boxes that, we now realise are so important?
Yeah, no, that's good. I mean, we found with the Nightingales, they obviously were something that had to be put together very quickly, and people had to act swiftly and make decisions. And on hindsight's probably going to be a wonderful thing on those as well. But I think there's some really positive decisions that were made at that point. And one of them that I see is around adaptability, because they went for systems and solutions which were adaptable and able to be moved and relocated, reset up. So taking the partitions, for example, then at the end of the project, so one or two of them, as they've been demobilized, now the partitions are being repurposed and reused for other purposes. And we've seen hospitals building facilities to cope with backlogs of patients in, for example, eye hospitals, dental hospitals, that we've been building negative pressure pods, for example, or extra assessment spaces. And that's as a result of the adaptability of the systems that were used at the Nightingale Hospitals. And the other thing I think that was really positive is around sustainability, because the materials used, they were 100% recyclable, and anything that couldn't be reused at the end of that project was in fact recycled. So it's a complete closed loop sustainability process going on there. And I think that's really key as we look to hospitals in the future, because we've got to be able to, I think we've got to be ready to adapt. If there was another pandemic, who knows how we might need to adapt our hospital spaces, and whatever we put in, I think it's important that A, they're adaptable, and B, they're sustainable. Giving an eye to the end game, what happens when it finishes? Are we harming the environment, or are we helping to protect it? So that's what I think. That's two real key takeaways I took from the positives from the Nightingales.
I think you're absolutely right there. Andrew Garner just says, I'm IPC lead in the NHS, and we now sit on all new build groups to look at compliance with building regulations, including all planning meetings. It's really helpful. So nice comment there from Andrew. Just spotted a question, actually, which I think might be relevant for you, probably, Chris. Jill says the importance and training of domestic staff needs to be given higher priority. They're not just cleaners, but a vital part of the IPC process. Is that something you'd agree with, Chris?
No, absolutely. I mean, I've spent, oddly and strangely, the last 40 years in education in cleaning, from across various qualifications across the industry, and even have a master's degree in education within the cleaning industry. So I'm really sort of sold on what education would bring to the industry, particularly, and I would just like to particularly mention the fact that, you know, cleaning staff don't always get the education which they either require or they need. Much of it is in-house, but there have been qualifications which are available for some time. I just really want to highlight the fact that, you know, right now we've got the new apprenticeship in cleaning, which started around about 3 years ago. We started the building of it. We've now got, and they decided to do it specifically for the healthcare cleaning operatives rather than for the cleaning industry as a whole. And it takes a year for the individuals to go through their full training, including 45 days off the job. So at the end of this, you would expect them to be pretty well trained in both the methodologies and the science of cleaning, as well as the practical aspects they need to cover as well. So I think that going forward, the new apprentices, or the new trained apprentices, the journeymen, if you like, will have a very real role to play in the facilities management of the hospitals for the future, simply because, well, I mean, to be perfectly honest, there's two reasons for this. One is that the NHS pays the levy, and they want to be able to call down their levy. And in order to do so, there has to be an apprenticeship. There's pressure, therefore, in the first instance, to create an apprenticeship that was eligible for the levy to be used. The second and more important thing was that we had a cohort of people within the cleaning industry, particularly cleaning and health education, that needed this training to be done. And as I say, it's taken over a year. We've got a number of candidates coming through at the present time, and probably in about the next 3 months, a large number of them will be coming forward for their independent assessment, which means that having done their apprenticeship, that they're not tested in-house, so to speak. They have to be independently tested by experts to make sure they've actually met the standard. I think that's something which will change in many ways the face of the domestic staff, the cleaning staff, or the cleaning operatives in the hospitals, and their knowledge and understanding and the professionalism of the industry.
To this one, Chris, if you can, because our time's ticking away and there's still a few areas to go on. But Richard says, as a lot of cleaning contracts are outsourced in the NHS, how are the cleaning contracts structured, and how do they monitor the effectiveness of their provider in maintaining clinically acceptable bioburden in the hospital?
It doesn't really matter whether or not they're in-house cleaned or whether they are cleaned by a contract cleaner. They have to conform to the same standard, and those are the new standards which have just been introduced. In fact, in April 2021, the new standards in the industry were introduced, which are called the National Cleaning and Healthcare Cleanliness Standards. So it doesn't really matter whether they are a contractor, it doesn't matter whether they're in-house, the same transparent methodologies and audits will be applied to them. And that'll be a 3-stage audit process, a technical audit, an efficacy audit, and an external audit if necessary. Well, next door anyway, just to make sure it's working.
How can electronic systems support efficiency in rapid response cleans?
Well, we've introduced an electronic system that links into our patient flow systems. So some of the electronic systems that we're beginning to use will identify what type of clean and where it needs to go and what the priority is, which it can help our rapid response teams work more efficiently. So we're making sure that we can prepare the bed areas for the patients that need to be prepared, so we can keep supporting our patient movement, which obviously we minimise, but sometimes we have to move some patients from one emergency care area to another. And really just building on that is that I think this is just the beginning of the programmes for us. In fact, I know it is. We need to build more electronic platforms. But actually going back to what's just been said by my colleague, I think the national cleaning standards is going to be an opportunity for us to look at actually what we're doing at the moment, look to areas where we might perhaps be overusing some disinfectants. And actually, I agree, look to see what it is that we can do to actually get the right cleaning at the right level at the right time. And one answer does not fix all. And finally, just to mention that the domestic service within our organisation are the infection control eyes and ears very often. We work very closely with them and they support us on all of our head of nursing audits and are very valued members of our team. But I think it's really, really important, and I'm very interested to hear about the opportunity for education, which is formal for them as well.
We've used the phrase learning curve. We've all been on that, whether that's been in our working lives or our personal lives or family lives. What would you think, in your opinion, needs to be in place to ensure that future projects optimise infection control? I wonder if Christine's not hearing me there.
Well, yeah, sorry, there was a bit of a delay on that. Yes, I think what needs to be in place is primarily a commitment from very high up within the NHS leadership regarding the importance of infection control in the built environment. So you can trip your staff up by not having the correct environment for them in which to work, and it makes it very, very difficult, even no matter how good you are at your hand hygiene. So you need to design your hospital to help your staff deliver the care. So the building's important not just for the staff, but also for the patients and for the whole community that's in and out of the hospital. So I think it just has to be right up there as a priority area, and it shouldn't be put in a risk register against some other aspect of resource allocation. So often infection control is competing. Organisations are looking at as a risk. And until the pandemic came, ventilation seemed like something you could get away with not really fixing for a long time. And that was never really a good place to be. And it was very short-sighted, because what you do is you build up the situation, that sort of idea of cheese layers and the holes in the cheese lining up. By not focusing on the built environment, we've allowed those holes to line up for this threat of the respiratory pandemic, which has hit us. So I think going forwards, people need to be awake. They need to be there needs to be systems in place to ensure that the standards aren't just sitting on a piece of paper at government or on a website or an email somewhere saying, you know, have a wee look at your ventilation. That's not good enough. We need actual standards that are implemented with auditable trails of inspection to prove that these are being met. Just like we do with MRSA rates, for example. It's not until you make a target and hold people accountable that suddenly resources is allocated. So I think there's a lot to do going forward, and we've started that journey even by the level of awareness that there is today. You know, before the pandemic, if you talked about air handling units or even the word PPE, people wouldn't know what you're talking about. It was kind of niche, but now everybody's got these concepts on their mind. So I think that's going to be a good place to go forward from.
And even our children as well. aren't they, as we go along. In a moment, I'd like to give the last word to you, Murray, but can I just squeak a quick question in, which I think will be for you, Christine? Antibiotic resistance to disinfectants is an increasing problem. Add to that the toxicity of, I can't say that, toxicity, she says, putting her teeth in, of most biocides, and the result is worrying. How important is it for the NHS to source and use toxic sanitizers which are not susceptible to antibiotic resistance?
The thing about bugs is that they do develop resistance to whatever we chuck at them, and the physical activity of a detergent is very effective for most. I think it's exactly as Gillian said, it's the appropriate cleaning for the appropriate setting. If you've got a bone marrow transplant, immunocompromised patients, you will have a different level of standard. If you have an outbreak of C. diff, you're going to do something different because that is a spore that's very resistant to environmental cleaning. So I think we need to be cleverer about our cleaning and more specific for what bugs we're targeting, what the patient group is, and we definitely have to have resistance at the top of our mind, because that is, you know, the biggest threat that we're facing coming out of this pandemic in terms of infection will be antibiotic resistance. So it's a very thoughtful question, and I think it's something that we need more evidence for, and more evidence around adequacy of cleaning. And this really hasn't been a failure of cleaning, this pandemic. We've done a lot of cleaning, and we've done a lot of good things with cleaning. This is a failure of airborne infection control, I think. So yeah, that would, I don't know if Gillian has more to answer on.
Oh, if you do, Jill, a quick one, because then I'm going to just let Murray end our session with the last question. Tim, do you want to add to that, Jill?
Well, I agree, and I think that's really what we're trying to do, and that's why we can use other electronic systems and the national guidance to support us in actually being more bespoke on how we manage our cleaning protocols.
How can estates work together then with infection control to ensure that building works comply with the required infection control measures?
Yeah, good. Well, from our point of view, what we see of it, there's enough. There's a lot needs to happen around just the builders themselves, the contractors, when they're working within the environments. There needs to be a communication between estates and between infection control, because there's during construction works there can be a lot of change, there can be a lot of opportunity for additional dust and cross-contamination to occur in a building, and we really see it's critical that that process is managed correctly. And that just in our aspects of it, what we see is even in the installation of partitions, it could be creating a partition to create a barrier to stop cross-contamination, but the very building of that partition could create dust and extra contamination in itself and additional cleaning requirements. So we're working a lot to create modular systems that are built off-site that can be installed cleanly without any dust created during that build, and we find that is a way that estates departments can work closer with infection control to ensure a clean build on projects.
I feel like we should have another debate on this tomorrow because there's so much to cover, and you all brought something very different to the table. So thank you very much to Chris, Gillian, Murray and Christine. That was really way to kick off our afternoon. Next, we'll be moving into our final networking break of the day, slightly longer this time. We'll have 25 minutes to explore the platform, engage with our speed networking functionality, or unwind before the next speaker and the final panel debate. I'll see you back at 2:55 for the next speaker, Claudia Paloni.